Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 168 of our Pharmacotherapy MCQ series, which majors in infectious diseases. A concerned parent presents to your family medicine clinic with her 8-month-old otherwise healthy boy concerned about an HIV outbreak at the daycare center where this boy is regularly dropped off for care on her way to work. According to news reports and local health department, 2 confirmed cases of HIV in children have been traced to this center. The source of the exposure is believed to be a chef who recently traveled abroad and acquired HIV from contaminated fruit salad and drinking water. So my question to you is, which of the following would be the most accurate concerning post-exposure prophylaxis in this case? Would it be A. Administer ribavirin 200 mg orally once daily for 2 weeks, or B. Administer inactivated HIV vaccine, abbreviated as VAQTA 1 ml at a dose of 50 units today and immunoglobulin 0.02 ml per kilogram, or C. Administer immunoglobulin 0.02 ml per kilogram today, or would it be D. Administer inactivated HIV vaccine, VAQTA 1 ml at a dose of 50 units today? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Administer immunoglobulin 0.02 ml per kilogram today. Post-exposure prophylaxis of individuals with recent exposure to HIV involves the use of the vaccine or immunoglobulin. In this case, immunoglobulin would be preferred. That makes answer C correct. Because the HIV vaccine is not approved for use in children younger than 1 year, answers D and B are incorrect. In healthy individuals 1 to 40 years of age, the HIV vaccine should be administered if it can be given within 2 weeks of exposure. Immunoglobulin 0.02 ml per kilogram is preferred for children younger than 1 year, adults older than 40, and patients who are allergic to HIV, are immunocompromised, receive hemodialysis, or have chronic liver disease. Ribavirin is not used to treat or prevent HIV infection, which makes answer A incorrect. Please advance to the next question. And the next question reads, TAK, a 26-year-old female patient with newly diagnosed HIV presents to the clinic to begin highly active antiretroviral therapy, HAART. According to her laboratory values, she has HIV co-infection. So my question to you is, which of the regimens listed below would be the best medication to incorporate into her HAART regimen for treatment of chronic HBV? Would it be A. Ledipasvir plus sofosbuvir, or B. Peginterferon alpha, or C. Entecavir, or would it be D. Tenofovir plus emtricitabine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Tenofovir plus emtricitabine. Tenofovir plus emtricitabine has antiviral activity against HIV and HBV. Furthermore, tenofovir is available in several single-tablet regimens and is a preferred initial regimen for HBV because of its high resistance barrier. That makes answer D correct. Entecavir is also a preferred initial regimen for HBV treatment, however, it is not active against HIV. Although entecavir would work, it would also increase the pill burden and potentially the cost. THST makes answer C incorrect. Although peginterferon alpha is active against HBV, it has no activity against HIV and has intolerable adverse effects. That makes answer B incorrect. Answer A is incorrect. Though ledipasvir, sofosbuvir is useful for HCV infection, it has no antiviral activity against HBV infection. Please advance to the next question. And the next question reads, TLA, a 57-year-old male patient with chronic HCV infection presents to the clinic for a routine follow-up. According to his vaccination history, he received 1 dose of HBV vaccine 1 year ago. He missed his last 2 appointments and has not completed the series. His pertinent labs are as follows: AST 75 international units per liter, ALT 80 international units per liter, anti-HCV positive, HCV RNA 120,000 international units per milliliter, HB. SAG, negative, anti-HB, S negative, IgM anti-HB, C negative, total, IgM and IgG, anti-HAV positive, and HIV positive. So my question to you is, which of the following would be the next best course of action in TLA's clinical scenario? Would it be A. Restart the series with 1 dose, Engerix B, 20 mcg per 1 ml IM now, at 1 month, and again in 6 months, or B. Administer single antigen HBV vaccine, Engerix B, 20 mcg per 1 ml IM now and again in 6 months, or C. Administer single antigen HBV vaccine, Engerix B, 20 mcg per 1 ml IM now for 1 dose, or would it be D. Repeat HB, SAG, anti-HB, C, and anti-HB's laboratory tests today, and have him follow up in 1 month to receive vaccine, PRN. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Administer single antigen HBV vaccine, Engerix B, 20 mcg per 1 ml IM now and again in 6 months. Answer B is best because the patient has received only 1 dose of HBV vaccine. The second dose should be administered as soon as possible, and the third dose can be administered in 6 months. The laboratory tests need not be repeated at this time because this would only delay the vaccination schedule. That makes answer D incorrect. The usual dosing strategy for HBV vaccination is a 3-dose series at 0, 1, and 6 months. That makes answer C incorrect. The entire series need not be reinitiated if the initial dose was administered and documented in the medical record, which makes answer A incorrect. Please proceed to the next question. And the next question reads, LDA, a 26-year-old female patient presents to her obstetrician, gynecologist for routine pregnancy care. She is in good health except for chronic HBV, which she acquired at birth. LDA's 5-year-old daughter is an inactive carrier of HBV. According to her pertinent labs, LDA has chronic HBV infection with HBeAg positivity and HBV DNA of 400,000 international units per milliliter. Her ultrasonography reveals that she is now 28 weeks gestation. So my question to you is, which of the following would be the best prophylactic treatment to prevent perinatal transmission to her child? Would it be A. Initiate sofosbuvir 400 mg orally once daily from now until postpartum week 4, or B. Initiate tenofovir disoproxil fumarate 300 mg orally once daily from now until postpartum week 4, or C. Initiate emtricitabine 200 mg orally once daily from now until postpartum week 4, or would it be D. Perinatal infection is unlikely because HBV DNA is less than 500,000 international units ml, and no treatment is required? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Initiate tenofovir disoproxil fumarate 300 mg orally once daily from now until postpartum week 4. This patient is at a very high risk of perinatal transmission because of a high HBV viral load is greater than 200,000 international units per milliliter, and she has another child with vertical transmission of HBV. That makes answer D incorrect. TDF has demonstrated decreased perinatal transmission in a clinical trial and is the best treatment strategy of the choices listed. That makes answer B correct. Emtricitabine has antiviral activity against HBV and is pregnancy category B, however, emtricitabine is not approved for the treatment of chronic HBV. That makes answer C incorrect. Sofosbuvir is effective for HCV, but it has no activity against HBV, which makes answer A incorrect. Please advance to the next question. And the next question reads, PPA, a 66-year-old treatment-naive female patient presents to the clinic seeking treatment for chronic HCV after reading an article on the newspaper. You obtain the following from her chart: AST 65 international units per liter, ALT 76 international units per liter, albumin 3.4 grams per deciliter, total bilirubin 1.4 mg per deciliter, HCV genotype 1A, HCV RNA 1,300,000 international units per milliliter, and absence of cirrhosis on liver biopsy. So my question to you is, which of the following would be the best regimen to treat PPA's infection? Would it be A. Sofosbuvir plus ribavirin plus pegylated interferon for 12 weeks, or B. Ombetasvir plus paritaprevir plus ritonavir and dasabuvir for 24 weeks, or C. Ledipasvir plus sofosbuvir for 12 weeks, or would it be D. Daclatasvir plus sofosbuvir plus ribavirin for 16 weeks? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Ledipasvir plus sofosbuvir for 12 weeks. Leadopasvir plus sofosbuvir for 12 weeks is best. That makes answer C correct according to the ION1 and ION3 studies. A shortened treatment course of 8 weeks can be considered in patients with a viral load less than 6 million who do not have HIV co-infection and are not African American and other blacks. Daclatasvir plus sofosbuvir is a recommended drug for genotype 1A infection, however, the recommended treatment duration is 12 weeks, and ribavirin is not needed in patients without cirrhosis. That makes answer D incorrect. Ombetasvir plus paritaprevir plus ritonavir and dasabuvir is a recommended regimen with high SVR for genotype 1A, but the treatment duration is limited to 12 weeks, and weight-based ribavirin is necessary. That makes answer B incorrect. Answer A is incorrect because pegylated interferon regimens are no longer recommended for HCV infections, given serious adverse effects and lower efficacy compared with DAA regimens. For treatment-naive patients with genotype 1A/1B without cirrhosis, the usual treatment duration for all recommended regimens is 12 weeks. Please progress to the next question. And the next question reads, WAC, a 49-year-old female patient with chronic HCV genotype 1B presents to begin therapy. She treatment naive and has never had decompensated liver disease. WAC's FibroSure test score 2 months ago was 0.85, suggesting cirrhosis. Her baseline labs were as follows: HCV RNA 650,000 international units per milliliter, serum creatinine 0.8 mg per deciliter, platelets 106,000 per millimeter cubed, hemoglobin 12.5 grams per deciliter, neutrophil count 3,400 cells per millimeter cubed. According to the current AASLD and IDSA guidelines, so my question to you is, which of the following would be the best regimen for WAC now? Would it be A. Sofosbuvir plus pegylated interferon plus ribavirin for 12 weeks, or B. Cimiprevir plus sofosbuvir for 8 weeks, or C. Leadopasvir, sofosbuvir plus ribavirin for 8 weeks, or would it be D. Elbasvir plus grazoprevir for 12 weeks? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Elbasvir plus grazoprevir for 12 weeks. Elbasvir plus grazoprevir for 12 weeks is best. That makes answer D correct. In the CEDGE clinical trial, the overall SVR was 99% in treatment-naive patients with genotype 1B, including those with cirrhosis 22%, and without cirrhosis 88%. Leadopasvir plus sofosbuvir is recommended for genotype 1B infection, however, the shortened course, lasting 8 weeks is not recommended in patients with compensated cirrhosis, and ribavirin is not recommended. That makes answer C incorrect. Cimiprevir plus sofosbuvir is an alternative regimen for genotype 1B, but the treatment duration should be extended to 24 weeks. That makes answer B incorrect. Answer A is incorrect because pegylated interferon regimens are no longer recommended for HCV infections, given their serious adverse effects and lower efficacy compared with DAA regimens. For treatment-naive, genotype 1A/1B patients with compensated cirrhosis, the treatment duration for all recommended regimens is 12 weeks. Please advance to the next question. And the next question reads, ALJ, a 67-year-old treatment-naive, female patient with chronic HCV returns for treatment initiation. 2 years ago her liver biopsy revealed evidence of cirrhosis. Her baseline labs are as follows: HCV genotype 2b infection, HCV RNA 2,100,000 international units per milliliter, serum creatinine 1.0 mg per deciliter, platelets 165,000 per millimeter cubed, and hemoglobin 11.2 grams per deciliter. So my question to you is, according to the current AASLD and IDSA guidelines, which of the following best reflects the recommended treatment regimen for ALJ? Is it A. Sofosbuvir plus Velpatasvir for 12 weeks, or B. Elbasvir plus Grazoprevir for 12 weeks, or C. Ombetasvir plus Paritaprevir plus Ritonavir plus Dasabuvir for 12 weeks, or is it D. Ledipasvir plus Sofosbuvir for 12 weeks? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Sofosbuvir plus Velpatasvir for 12 weeks. Sofosbuvir plus Velpatasvir for 12 weeks is the only recommended regimen for patients with cirrhosis with HCV genotype 2 infection. That makes answer A correct. Dactatasvir plus Sofosbuvir for 16 to 24 weeks is an alternative regimen. Ledipasvir plus Sofosbuvir, Elbasvir plus Grazoprevir, and Ombetasvir plus Paritaprevir plus Ritonavir plus Dasabuvir do not have appreciable in vitro activity in genotype 2 infection. That makes answers B to D incorrect. Please progress to the next question. And the next question reads, YAB, a 66-year-old male patient with chronic HCV genotype 3 presents to the clinic inquiring about treatment. YAB's previous fibro test score was 0.93. He underwent transient elastography, whose result was 17.5 kPa. Both of these results were consistent with compensated cirrhosis. He has a past medical history significant for hypertension and GERD. His current medicines include lisinopril 10 mg once daily and omeprazole 40 mg twice daily. So my question to you is, which of the regimens listed below would be most appropriate for YAB? Would it be A. Initiate Velpatasvir plus Sofosbuvir for 12 weeks? Reduce omeprazole to 20 mg once daily, taken 4 hours after Velpatasvir plus Sofosbuvir, or B. Initiate Velpatasvir plus Sofosbuvir for 12 weeks, continue omeprazole as prescribed, or C. Initiate Ledipasvir plus Sofosbuvir for 12 weeks, reduce omeprazole to 20 mg once daily, taken 4 hours after Ledipasvir plus Sofosbuvir, or would it be D. Initiate Ledipasvir plus Sofosbuvir for 12 weeks, continue omeprazole as prescribed? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Initiate Velpatasvir plus Sofosbuvir for 12 weeks. Reduce omeprazole to 20 mg once daily, taken 4 hours after Velpatasvir plus Sofosbuvir. Valpartisphere plus sofosbuvir for 12 weeks is a currently recommended treatment for HCV genotype 3 infection. Co-administration of valpartisphere plus sofosbuvir with omeprazole 20 mg reduced the valpartisphere area under the curve and maximum concentration, C.max, by 36% and 37%, respectively. That makes answer B incorrect. Avoiding a proton pump inhibitor, PPI, or changing to a histamine 2 receptor antagonists is a recommended strategy. However, if a PPI must be used, omeprazole 20 mg should not be exceeded, and valpartisphere plus sofosbuvir should be taken at least 4 hours before omeprazole. That makes answer A correct. Ledipasvir plus sofosbuvir has inadequate activity against HCV genotype 3 infection. That makes answers D and C incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support, and kind collaboration. We look forward to interacting with you in the next video, which will be part 169.